over to Dr. Reed.
Good morning. I am very happy to welcome a special guest that we have joining us today, Dr. Susan Meister. Dr. Meister, morning, Dr. Meister. She received her undergraduate and doctoral degree from the University of Michigan and has, as you all know, has dedicated her career to advancing child health policy. She's been a long-term supporter of CHEAR and is actively involved in our research, and importantly, its dissemination. So we're really happy to have you join us today, Dr. Meister. It's nice to see you. And I'll go ahead and pass it over to Courtney to introduce our speaker.
Thanks. So Dr. Megan Pesch is a developmental and behavioral pediatrician at CS Mott Children's Hospital and an assistant professor at the University of Michigan Medical School. She received her MD and her master's in clinical research from the University of Michigan. She also has a bachelor's in French from the University of Massachusetts. Her research focuses on health services delivery around congenital diseases and childhood obesity. She also serves on the board of directors of the National CMV or Congenital Cytomegalovirus Foundation. CMV is a common cold virus that can cause hearing loss and other delays. She also examines how mothers' feeding and eating behaviors may influence their child's risk of excess weight gain. Megan is a mom to 3 girls, which is especially admirable during the pandemic. Her youngest is born with congenital CMV, and she is an enthusiastic advocate for research and efforts for parents and children who have been infected with CMV, and that is obviously very close to her heart. So we're really excited to learn from you today and look forward to your talk. One question I should ask you, would you prefer questions at the end or as we go along?
Ooh, well, maybe I should have asked this before. If someone asks a question during, are they able to just kind of interrupt and speak up, or is
you can do it
does
either
it need
way.
to go through the chat?
We could put it in the chat, and I could just let you know when I see it in the chat.
Oh yeah, let's do that. Yeah, that'd be great. But yeah, throughout sounds good. I think I'm hoping this will be more of a discussion rather than a lecture.
Perfect, sounds good. So I will be watching the chat if people would like to put their questions there.
Great, and is everyone able to see my slides? Okay, perfect. And before I get started, I have a 2-year-old doing speech therapy in the next room, which is not her favorite thing to do, most favorite thing to do. So that's why if you hear screams, that's what's going on. So nice to be here, and it's really just a privilege. I am a developmental behavioral pediatrician and have been doing obesity research for the last 10 years. So I'm pretty new to this space, especially to health services research. So it's an honor to be here, and I really consider myself here among experts. So feedback, ideas, collaborations, I'm very much open to. There we go. So today what I'll do is we'll just talk quickly, and I'm going to give like a 30,000-foot overview of the epidemiology and possible outcomes of congenital CMV, which is cytomegalovirus. I'll talk about the gaps in the literature, and then talk about screening for congenital CMV and policy that exists right now to support that. I am now the president-elect of the National CMV Foundation, which is unfortunately unpaid, and they have had no contributions to this talk. So here's our story, and I know we've kind of skipped to the punchline already, but this starts about 3 years ago, and I was pregnant with my 3rd daughter, and it was a healthy pregnancy. All the ultrasounds were fine. I gained weight, the baby gained weight. It all just seemed totally normal. I was tired, but I had these 2 rugrats that I was running around after, so it seemed normal tired, and just generally felt good. I delivered my daughter at term, and it was a bit of a rough delivery in terms of her positioning. And I mentioned that because when she was born, the sweet thing had like her forehead was all swollen, and she had gunk in her ears, and then she had all these little pinpoint spots on her face, which are called petechiae. And, you know, we just thought it was from her being stuck. And when she failed her newborn hearing screen, we were not worried. I had spent, you know, my last 6 years in training, reassuring anxious moms that, oh, the newborn hearing screening, you know, the false positive rate is 90%. And I was determined not to be that anxious mother. And also, like, looking at her, I just thought, oh, like, who wouldn't fail their hearing screen, like, looking like that? But we took her home, and, you know, she's truly the most perfect baby. But at around 2.5 months, we went back for her repeat screening and found out at that time that she has a bilateral profound hearing loss, which means like absolutely no hearing in either ear. And through a bit of a diagnostic odyssey, we found out that it was indeed from congenital CMV, and that she has you know, pretty significant intracranial involvement and abnormalities as well. So fast forward to now, this is my little monkey. Her name's Odessa. So she has bilateral cochlear implants. She certainly has some challenges, but gosh, we couldn't be more proud of her. She's saying single words. Her latest word is hippo. We're just so proud. But we also know that, you know, her life is going to be more difficult than, you know, maybe it could have been. So as a mom, but also as a researcher and a clinician, I really have dug into the literature around congenital CMV since she was born. And a large reason is because it was just not on my radar as a mom, as a clinician, as a researcher, and I don't think it's on a lot of people's radars. So I will share with you what I've learned and some of the work that I've been doing around this in the last couple of years. So cytomegalovirus, so that's the virus, is a cold-like virus. It's usually no big deal in most people. It causes maybe like a sore throat, some lymph nodes. Most people have no symptoms. It's really generally a no big deal. But if a woman gets it when she's pregnant, around 1/3 of women will transmit the virus to the fetus. And so when the fetus is infected, that's when we call it congenital CMV. And CMV is a nasty virus for babies. It damages the placenta, and it also is very much attracted to fetal brain cells, particularly astrocytes. So it really replicates in that fetal brain and, of course, disrupts that brain development. So this is what I still can't get over. 30,000 babies are born in the States each year with congenital CMV. 1 in 200 live births. And we are just not talking about it. And I know I don't live like, you know, in a total vacuum, but it's not on my radar, and I don't think it's on most people's radars. But it is a significant contributor to neurodevelopmental delays and hearing loss. So when we think about babies that are born with congenital CMV, we've kind of put them into 2 buckets to describe disease severity. And of course, it's a spectrum of disease, and these are like artificial buckets, but this is kind of how the research has really dichotomized them. So 10% are considered symptomatic, and symptomatic means babies with visible signs at birth and or laboratory abnormalities and or CNS involvement. And then the asymptomatic babies, which is 90%, most of them, look totally normal at birth. There are no laboratory or intracranial abnormalities, but they can have hearing loss. And the hearing loss can be profound, yet they're still termed asymptomatic, which I think is part of the problem. It is such a falsely reassuring misnomer for parents and providers alike when these babies are at higher risk of profound hearing loss. So again, what do these babies look like at birth, and how do they do long-term? And again, 30,000 foot view. I'm happy to go into details with anybody about more nuances of this. The symptomatic babies, they often have 1 or more subtle findings. So the more severe cases are really like very rare. Most babies have maybe some jaundice, maybe like my daughter, some petechial rash, which we see in normal unaffected babies too. 40% will end up developing hearing loss, and of those symptomatic babies, 60 to 80% will have additional long-term sequelae. And if you think about the brain involvement, it's things like cerebral palsy, epilepsy, vision loss, so pretty significant disabilities. The asymptomatic babies, they look fine at birth, but 10 to 15% will develop hearing loss over childhood, which is significant. And most have normal outcomes, and I put that in quotes because I'll share with you why I think that really hasn't been looked at enough in the literature. And I'm personally not comfortable settling for that. So congenital CMV is underdiagnosed and undertreated. It's estimated that only 1% of cases in the US are picked up and therefore treated, leaving a large number of children undiagnosed, untreated, and missing those opportunities for early medication and early intervention. And there are lots of issues that I think contribute to this problem. So low public awareness. Again, we don't understand the developmental outcomes or the natural history very well. So I think it's hard for people to get concerned about a disease if we're told that 90% of the kids, they just do fine. There are limited disease-specific treatments, low provider awareness. It's tricky to diagnose, and prevention methods are not well researched, and they are not supported by the American College of Obstetrics and
Are you still able to hear me? Yeah, okay. Something weird happened with my audio there. Sorry about that. All right, press on. And we don't know the economic burden of the disease, either the cost effectiveness of screening or, what truly, the true implications of the disease, the spillover effects on families. And I don't think we can answer that question until we start screening or picking up more babies. So today I will focus, there we go, on 3 of those problems and just share with you some of the work that I've done and am doing and the ways I'm kind of thinking about addressing these issues. So let's start with developmental outcomes. So I touched on this briefly, thinking about the developmental outcomes of these kids and having had their brains infected by a virus during fetal development. There's a wide range of possible outcomes. And really a lot of these have been linked. There are a few others that I think are being increasingly studied and found to be at least associated with congenital CMV. So increased risk of cancers, leukemia and glioblastoma. Vestibular disorders are seen in maybe about 80% of kids. So balance issues, which can also associate with gaze tracking and like reading difficulties. And autism spectrum disorder. And again, these are areas of active research, the ones I've starred. So there's no causal link yet, but I hypothesize that there is. So why do I question, do 90% of children really have normal outcomes? And that's because the research to date has been very limited. The measures that have been used to assess development in these kids have been super blunt, and the outcomes are just kind of combined to clinically useless and meaningless categorizations. For instance, a lot of the data or a lot of the research on these children have ultimately their outcomes are normal versus abnormal development. And abnormal development can be anything from having one hearing aid to spastic quadriplegia. And like that range is like clinically meaningless. And, as a parent wanting to look at prognosis, like that is just too wide of a gap to be helpful at all. And also these studies have been mostly in convenience samples, retrospective cohorts. So the kids that have been picked up, which is probably biased to the most severe cases. Only 2 have gone into adolescence. And there are just inconsistent definitions of asymptomatic, symptomatic disease burden across country or across studies. So it's really like comparing apples to oranges. The cross-sectional studies are kind of the rule rather than the exception, and the longitudinal ones are usually just across 2 time points, which is not it's not enough to evaluate development, which is not a state, right? Or it's not a single time point. Development is fluid. So I think what's needed and what I'm hoping to address in a K award that I'm putting together right now is I really want to do granular developmental assessments, working with a population cohort that's being screened right now in Minnesota using universal screening. I want to follow these babies prospectively, asymptomatic, symptomatic, and controls. I mean, like if I had my way and got continuous R01s, it would be through adolescence. We can dream. And using expert consensus data or definitions of disease severity and using multiple measurements over time. So I plan to follow these kids every 2 months and look at their trajectories of development. That way you can see, okay, like who is falling behind, who's narrowing the gap. Is the trajectory increasing, or are they just kind of on their own sort of delayed trajectory and that's where they're at? I'll also share with you some work that I'm doing right now around congenital CMV and autism. And clinically, I see kids with autism. That's kind of like my niche in developmental pediatrics. So autism in toddlers and early preschoolers. And I've since started seeing kids with congenital CMV, and I think 60% of the kids that end up in my clinic, which again, selection bias, but they have co-occurring autism. And there are some studies that have shown an increased prevalence of autism in kids with CMV. And if you think kind of about the neuropathology of congenital CMV and some of the hypothesized neuropathology of autism, the pathways are similar. I'm not saying that congenital CMV causes all of autism at all. I think in some kids, it may be a risk factor. So just know that. So this is why I think this is so important to understand. If congenital CMV does increase risk of autism, then public awareness and preventative measures around congenital CMV plus minus CMV vaccine could decrease congenital CMV and decrease autism risk, which that would just have such significant public health impact. I would also just love to be involved with any project that contributes to a vaccine that decreases autism risk. As a pediatrician, that would just be so satisfying. So Scott Gross at the CDC has been a great mentor and has been kicking around some ideas with me about could we use administrative claims data to examine the prevalence of autism in children with and without CMV. Now, I am like a claims data novice. So I know I'm among experts, and I love either after or now just to hear some ideas about, could this be feasible? I know that there are limitations to working with claims data, but I do think it could be really interesting to look at the co-occurring diagnoses, so it's severity of disease and so forth, and really important for cost analysis of the economic burden of CMV, because autism is expensive to treat, ABA therapy. So I think this is an important piece of kind of the puzzle. Another study that I'm working on is I'm working to recruit right now 300 children in Michigan with autism. We are then retrieving the remnants of their newborn dried blood spots, so the metabolic screening, which is stored in Lansing, and sending those dried blood spots for CMV testing to Minnesota and calculating the prevalence. I think either way, this will be interesting results. The studies that have done this so far have been had cohorts more like between 21 and 80. So I think this will be really, really telling. And we are using gold standard diagnosis method of autism in this study. Okay, so let's shift now to diagnostic challenges. So as I mentioned, the signs are often subtle at birth. I don't think I ever picked up a kid with congenital CMV in my training. The asymptomatic babies or symptomatic babies can have no visible signs at birth, and there's an urgency for diagnosis too. Testing has to be done before babies are 21 days of age, or else it's really tricky to distinguish a congenital infection from a postnatal kind of like a cold, which is generally harmless. And early treatment, so specifically with antiviral medication, which only certain children are eligible for because of the associated toxicities. But those need to be started in the first 31 days of life, as they have been associated with improved long-term hearing and developmental outcomes for the symptomatic babies. And so my daughter like totally missed this window, but it's tricky to pick up and there is an urgency to it. So I wondered, how are we doing nationally? We don't know. It's not a reportable disease. So it's really hard to get a sense of how many cases are being picked up. Oh, got it. Oh, sorry, I just see a question popping up here. Perfect. If someone is positive for CMV IgG later in life, could that be congenital CMV versus postnatal CMV? How would you distinguish between these two possibilities in your cohort of children with autism? That's a great question, Cal. So we are not looking, so CMV IgG, right? That's the, shows that you've had exposure to CMV sometime in your life through that antibody, and it could be prenatal or it could be just a cold. And most people do end up being exposed to CMV at some point. What we're doing in my study is we're looking at their newborn dried blood spot. So the dried blood spot that was collected from their heel poke within the first or at 24 hours of life. And then we're doing a PCR to look for a presence of the actual virus at that time. So that's how we're working around. But I totally agree that it is really challenging when children are older if you don't have that dried blood spot, which we are one of the few states that actually keeps them all the way back to the 80s. So if anyone's interested in theirs. And so without that dried blood spot, you can't tell the difference.
I have a question as well that I didn't put in the chat, but do you think there's any role in testing mothers?
Oh, yeah.
Okay.
Hot topic. Totally. So I'll just say briefly, because I think we could go into this. I think there could be. It's very controversial because if a woman tests having like signs of previously having the infection, they are still at risk for reinfection with an additional strain, although the risk is significantly less. If a woman shows having never had the infection, then I think that is super helpful in terms of, while we really need to take safety precautions. And the way CMV is prevented is really through avoiding contact with bodily fluids, especially those of toddlers. So I was like the prime setup with like 2 little kids at home. Like like my house was a mess. There were like half-eaten waffles all over the place. I was pregnant and hungry. Like I absolutely ate that waffle, that had a bite out of it. Had I known, I may not have. The thing that gets controversial about the antibodies is if you test for IgM, which is the more acute phase antibody, that's really non-specific. So it could mean that someone had an infection within the last month or 2, or it could be a year ago. And dealing with that nuance, I think, is out of the comfort zone of a lot of OBs, and ACOG has not really put their nickel down on any sort of algorithms to really help differentiate. So I think so. I think it would be great. I think that I could go off on my feminist rant here, but I mean, I think women can handle nuance, and it would be better to know than just not know or worry about worrying women. I know that's an oversimplification, but that's where I come from.
That's great. Gary Fried also, So you have a few questions.
Oh, great.
So this is from Gary Freed. If I see an otherwise normal IUG, or for those who don't know, sorry, my dog, intrauterine growth restricted newborn for their first outpatient check at 3 to 4 days of life who passed their newborn hearing screen, do you recommend they be tested for CMV?
I do. Wouldn't it be great if there were like AAP guidelines to help us with this? So that's a massive limitation, is the AAP has been largely silent on management of congenital CMV. I think it's pretty low hanging fruit to check a urine on these babies, but there are no official guidelines saying as such. I think you should.
And then I'll follow up with the next question from Kevin. Will you aim to assess multiple births as part of your initial study?
Ooh, which one? The so many studies. We have seen, you mean like multiple gestations, like twins and so forth?
I'm assuming for the blood spot test. For the blood spot
yeah,
test is Kevin's specific question.
So it is super wild that we like the royal we in the literature have seen twins with one has presented with congenital CMV and one is not infected. So I think right now we're just able to say, for each child what was in their blood at birth. I think it would be really interesting to do a twin study eventually, but right now we're just recruiting the children with autism. If there are 2 children with autism from the same family, we'll look at both of them.
Great. All right. My dog has calmed down, so I can ask the next question. Sorry. Kara asked, is there an available treatment for pregnant women with confirmed CMV? I suppose that would inform the rationale for screening pregnant women.
Mm-hmm. Yeah.
And Cal, related to that, it was also asking, just to play devil's advocate, is there any advantage to basically detecting earlier, screening earlier?
Right. And in pregnant women, I'm assuming. Yeah. So there are no strongly evidence-based treatments to decrease the risk of vertical transmission or really improve fetal outcomes during pregnancy with known congenital CMV. I will say that earlier this year, there was this really exciting study that was published in the Lancet, done from this Israeli group they're really much more bold than us Americans. And they gave antiviral medication, so valganciclovir, to pregnant mothers who had tested positive for CMV. And they do much more prenatal screening and so forth. So that's how they were able to catch these mothers early. And they showed 61% decrease in vertical transmission with the use of valganciclovir. I think there are a lot of other questions around toxicity and that haven't been answered, but there may be. And I think so knowing about CMV earlier, and this is controversial, but women, they may choose different outcomes for their pregnancy. And I'm not supporting that or against that. I'm just saying that more information can be empowering. Also to kind of better prepare. And the fact that we miss most of these babies after they're born, even if earlier that a baby has CMV in utero or is at high risk, then you can really prepare for that pregnant or for that delivery and care for that neonate.
Great. And one last question related to this. 2 last questions related to this, and then we'll let you move on. So do we know what time in pregnancy transmission occurs? This could also be important to inform screening trajectory. That's from Jeremy.
Totally, yeah. So early on, so this is I think fascinating. So the earlier a woman is infected in her pregnancy or even prenatally in the weeks leading up to conception, because of the viremia is as such, that generally the worst outcome for the infant, which totally makes sense. However, assuming it's a little bit different in the transmission risk or infection to the infant, depending on if a mother has had CMV before or not. But let's just like play out the worst case scenario. So if a woman has never been exposed to CMV before, the earlier she's exposed in her pregnancy, the lower the transmission risk to the fetus. Why? I don't know. I think it's really fascinating. And as the pregnancy progresses, there's a higher risk of vertical transmission. Of course, the damage is much less if you're infected in the late third trimester and that brain is already developed versus, really early on. So yes, it's a little bit complicated.
Great. I think we'll let you continue.
Okay, thanks. No, this is great. This is great. I'll try to kind of forge ahead here. Basically, we looked at what we were doing at Michigan Medicine in terms of testing for congenital CMV by looking at the medical records over the last 7 years. And let's see, there we are. And what we learned was over the last 7 years, there were 22,800 babies born at Michigan Medicine. Of those, 245 had tests for CMV ordered in the first month of life. And looking at the medical records, 95 of those were tested for like respiratory infections, more like postnatal CMV, not the congenital. Of the 179 that were tested for congenital CMV, there were 12 confirmed cases over the last 7 years. So if you look to see, well, what's kind of like our rate of testing, or how many babies are we testing? So we're testing at 0.007% of babies born at Michigan Medicine. And our detection rate, what we're detecting, diagnosed prevalence, I guess you could say, of 0.0005%. And if you look at what would be expected, you expect a prevalence of 0.5%, or even like a prevalence of symptomatic cases at 0.05%. So we are just off by a huge scale in terms of the babies we could potentially be picking up. Whether or not we should be picking up, I think is controversial, but I bet you can guess where I stand on that. And I'll just skip this in the interest of time. So let's quickly move to low provider awareness. Now, there have been no studies assessing the awareness of pediatric providers about congenital CMV or their practices in the last 20 years. In the US. There was one from Iran, but that does not exactly relate to us. So I decided, because I didn't know, and I feel like a lot of my colleagues and people that I've spoken with, it was not on their radar either. So I just wrapped up data collection on a study where we did virtual questionnaires with 103 primary care and newborn hospitalists from Michigan. And the survey was about their awareness and knowledge and education about congenital CMV. So these data I got, I think, on Tuesday. So I'm just going to highlight what I found so far. I need to do some more digging. So of the pediatricians, only 23% knew the prevalence of congenital CMV as being 1 in 200 babies. And the other answer options were 1 in 1,000 or 1 in 5,000, so quite different. 41% knew the time frame for testing for CMV is 21 days. The other options were on the scale of 3 to 6 months. 87% knew the correct test to order, but only 61% knew that asymptomatic children were still at risk of hearing loss. And in terms of their attitudes, here 19% felt comfortable diagnosing and managing congenital CMV. Only 15% agreed that the diagnosis and management of CMV was sufficiently covered in their medical education. And 99%, except for one curmudgeon, said that they would be open to learning more about congenital CMV management in the future. So, why these overall low numbers? I think we've touched on it. It's really underemphasized in medical education. And I think that stems from, the AAP being largely silent on it, as well as ACOG. So, primary care pediatricians have to go off AAP and, how is this going to get on their radar otherwise? So I think there is a significant gap that could be filled here. So we've talked about outcomes, the low provider awareness, and the diagnostic challenges. All of this, I think, could be potentially addressed by newborn screening. And it's a controversial topic. It's not as straightforward as I'm going to present it as. I recognize the significant nuance that goes into this, but just for the sake of this presentation, I kind of wanted to give an overview of where things are at. So right now in the States, we have, or right now, I guess in the world, there are two types of CMV screening. Hearing targeted is when you target the CMV testing or the screening to the babies that fail their newborn hearing screen. And then universal, you're testing all the infants. So the advantages of hearing targeted screening is you're able to pick up 57% of babies with CMV associated hearing loss, but you're missing 43%. And I think that is because the hearing loss associated with CMV can be rapidly progressive. It can be fluctuating, especially early on. So that's a big chunk to be missing. Potentially, it's more cost effective. The literature is kind of inconclusive about this. Possibly you're ordering less tests, less babies to follow up. But the big disadvantage is that these babies who fail their hearing screen are often lost to follow up. So at Michigan Medicine, we lose somewhere between 30 to 40% of infants who fail their hearing screen. And we're a referral center, so I'm talking about all comers who fail their hearing screen in person, or sorry, in the hospital, and then follow up to be tested. So if you're not testing a baby until after they've failed their second screen, which most institutions do, you're already losing like a big chunk of this potential 57%. So universal screening, hypothetically, you're catching 100% of infants. And that is really where I feel like you're going to be able to truly assess the natural history, the developmental outcomes, the economic implications. It's going to be logistically challenging though. The dried blood spot is not a very sensitive test, so it's not easy to just kind of add that on. And the preferred sample is urine or saliva, which is not easy to collect in a baby, and there are just other logistical challenges. Potentially less cost effective, just with more tests being ordered, but again, we don't really know. So a question I get often is, well, why diagnose symptomatic infants? Like, should we really just be targeting, or asymptomatic infants? Should we really just be targeting the symptomatic babies because they are eligible for that antiviral medication? I argue that treatment is not just medication. So treatment includes evaluation, therapies, anticipatory management, and guidance. So you can't know a baby is asymptomatic unless you check labs and do a quick cranial ultrasound to see if there are intracranial abnormalities. And these babies are at risk of pretty significant hearing loss throughout childhood. I have two patients right now who are typically developing, one at 4 and one at 9, lost hearing rapidly, and they had not been diagnosed with CMV at birth. The 4-year-old, it's really unclear how long her hearing was gone for. She's typically developing. The 9-year-old lost it in both ears within a few months' time. And there was about a 6-month period of him being worked up for cochlear implants in which he had no access to sound. And he's not a signer. It was verbal communication that he used. Also, if there are emerging delays, those can be addressed early on. But it's controversial. We don't know about the costs. We don't have the ideal screening platforms. And it's certainly going to be logistically challenging. They said that about newborn hearing screening too, and it took a while for that to gain in popularity. So I think if we can do that, we can do congenital CMV screening, but it's not going to be easy, and it's not going to be pretty, at least at the beginning. So let's shift and talk about the state of policy in the US. So this map is from about a year ago and added some updates. So the turquoise are states with some sort of law about congenital CMV. The mint are the ones that have laws proposed, and the orange have other laws, mostly about educating healthcare providers. So here I kind of put these purple stars on the states that have current newborn hearing screening related CMV laws. And these red ones, there are Massachusetts and Kentucky have recently introduced universal screening bills, and I'm happy to talk to anybody about my opinions on those bills and how they are great or not so great. But I'll just kind of skim over that and focus on the policy that we have currently enacted. So these are the 6 states that have existing policy, and you can see they've all been enacted over the last decade. None of them have any appropriations, and most of them have fiscal notes. In Connecticut, they have a screening and a reporting mandate, meaning you have to screen the babies who fail their hearing screen, but then you also have to report that to the Department of Public Health, which I think is a really important component. Illinois just requires that parents be given like a pamphlet about CMV before they leave the hospital, saying that it could be associated with hearing loss and they could be tested for it. No conversation has to happen, and it can just be slipped in to like a discharge paperwork packet. In Iowa, they just say that the healthcare provider has to screen before 21 days, but no other guidance is given. In New York, they just say it has to be with urine PCR. When? I don't know. How? Not clear. What do you do with that? I don't know. Utah, on the other hand, has the most robust law, and in terms of they specify what tests to do, where to send it. It's a central lab. They do this on an outpatient basis, so they're able to bill private insurance, and so this is like a financially self-sustaining program. Their early hearing detection program owns the results and follows those babies. There's also detailed reporting and tracking and clinical care algorithms. And then Virginia is pretty new, and it is built on Utah's framework. So does this policy help, or does it work? Well, only Utah has published data about whether or not it's effective. So 24 months, they looked at the data 24 months before and after the legislation was enacted in 2013. So this is even a little bit old. So 62% of those infants who failed their hearing screens were screened for CMV during that time, and they found 14 cases of confirmed CMV. Now, I don't know what their baseline was, and nobody does, so it's hard to know if that's a significant improvement or about the same. I think one interesting thing that came from this is that the infants who failed their hearing screen, and also were tested for congenital CMV, were nearly 3 times more likely to follow up and complete that diagnostic hearing evaluation. And maybe that's because we're kind of putting the fear in them a little bit, like this could be something serious. So that was an interesting and unexpected finding, but I don't really think this tells us whether or not it's an effective policy. So what makes the program effective? I think you have to assign responsibility. You've got to track these kids. You need testing infrastructure. You need a follow-up plan. Let's see. So this, I'll just show you briefly. This is from the Iowa Department of Public Health. Here's this algorithm. They said this is how what you should do with the CMV screening. So it basically says you screen the hearing, you screen again, you order the CMV test, you test the hearing, and then it just ends. Like there's nothing below that, like what you do with the test or who follows up or what happens next. And without guidelines from the AAP, I think this puts primary care physicians in a really tough position. In Ontario, they have an alternative approach that they've started. So it's through their newborn screening department. And basically what they've done is they now offer all parents, when their babies are screened for hearing loss, when their babies are screened just with their regular hearing screening, they say, would you also like us to add on screening for permanent hearing loss risk factors? And like 99% of the parents are like, oh yeah. So then they just add on the CMV PCR and some genetic markers to the dried blood spot. So their dried blood spot PCR has super low sensitivity. So they're picking up their prevalence that they found is 0.1%, and we would expect 0.5. And that's due to the PCR. But in the first 5 months, they picked up 52 infants, which is something. It's more than zero. And while I think this program has a lot of room for improvement, I think this is an example of not letting the perfect get in the way of the good. Like, this is good. There will be improvement. I'm excited to see where this can go. But at least they're doing it. And they found that the babies who are identified with CMV-associated hearing loss have a much faster time to cochlear implantation, closer to 6 months versus here, at Michigan, we're more like 15 months. So I'll just briefly touch on CMV vaccines, and I'll end there. So there have been some recent exciting advances. In 2019, through the foundation, we started kind of talking to a small startup in Cambridge about their vaccine platform, which seemed really promising, and now it's in phase 3 trial. That small startup company is Moderna, and so they've recently come into some money. I really should have bought stock back in 2019, but they're throwing a lot of resources behind the CMV vaccine development, which I'm hopeful for. But even if you have the best vaccine candidate, if there's low awareness or really low vaccine acceptance, it's not going to matter. So how do you build a market for a vaccine for a condition that few people know about? And I think this is going to be the biggest issue. I think that it is going to have to start with universal screening. So if you screen all the babies, everyone's going to know somebody with a baby affected by CMV, asymptomatic or not, or symptomatic. And that in turn will increase awareness, which will increase people's adherence, or even just knowing about preventative measures, increase vaccine acceptance, and ultimately, this is the goal, is to lower congenital CMV incidence. So I'll stop there. There's my cutie. She discovered her belly button last summer, and I'll pause. Thanks. I know we're pretty close to time here.
That's great. Yes, when they discover the belly button, it's lots of fun. So we have quite a few questions here, and people can continue to put them in the chat. So there's a little back and forth. Cal, do you want to say yours? I feel like that's better said than my trying to say it.
Oh, I was just, it's a personal anecdote, which was that my mom was a basic science researcher who was experimenting with CMV when she was pregnant with me, and there was pressure, or at least a conversation from my grandmother apparently about whether it made sense to terminate. I only bring that up because I do wonder that without information on kind of what we can do about a positive screen, what the actual risks are of having a positive screen, is it premature to advocate for universal screening without have that downstream knowledge? Because what you might end up with is a bunch of people who, I don't know, make a decision based on kind of a limited understanding of the actual implications, which could have some downstream consequences.
Mm-hmm. And are you thinking, sorry, about universal screening in pregnancy or of
I think in pregnancy, I think that's right. I mean, and so, yeah, so I mean, those are two different things, right? You can universally screen infants, or at least screen infants who have hearing loss.
Yeah, I don't totally see your point. In pregnancy, you can confirm with an amniocentesis, but that's not without risks. So the obstetric side of this is really not my my specialty, but I will say, there are other countries, like France has a very robust program where they do universal screening in the first trimester, even before pregnancy, and then they double down on the education about preventative measures for women who are seeing or have never been infected. And so like even just that, I think could be really helpful. I totally understand though that like the IgM is really hard to interpret. So I think if one was to really kind of dive into that and look at the pros and cons, learning from what they do in France and Italy and Israel, I think would be really helpful.
Jeremy commented to this too. Shows the importance of needing good data. Need to know the risk to the child, and it seems like early intervention makes a difference in outcomes. And now I'm going to skip to related to what you just said. Jeremy also asked, do you know about policies and outcomes in other countries? UK has universal hearing screening and early intervention with home visit for families of infants with deficits. Are there best practices identified elsewhere?
Yeah, it's a great question. So I think Italy is probably our best example of a universal hearing screening. And you know, they do catch more infants. It's really hard to know with just the hearing targeted screening if what babies were missing and how things would have looked otherwise, if that makes sense. So I think it goes back to your first question or first comment about, you know, lack of really good data to inform practices. I know like there are no countries that I know of that do universal screening that have very good data to share. I think the program in Ontario is going to be kind of the start of that. And I'm hoping that this study that's going on with the CDC in Minnesota right now, they're aiming to screen 30,000 infants universally. I'm hoping that a lot of good data will come out of that.
Great, thank you. Two other comments, not questions. David Sandberg said, consider reaching out to the CARES Foundation, which he put the link in there. I don't know if you're familiar with them, but they've been instrumental in screening for congenital adrenal hyperplasia in all 50 states. They are also knowledgeable about the legislative process. Right. And then there's also a comment, there's a link to an article about a CMV infection in an older adult that led to death. And then Sheng commented, thank you. I don't know if Sheng, if you want to comment, but thank you for sharing your knowledge and research on CMV. This made me realize that I might have been exposed to CMV due to my bilateral hearing loss. I'm sure there's a lot of people who'd probably have that similar questions. So one of my questions that I had in trying to kind of push universal screening, I would imagine, I don't think we currently collect urine or saliva for prenatal screening. Okay, not totally, that's not my field. But are there any other conditions that people would want to collect urine or saliva for? You could kind of piggyback together in advocating for it that you know of?
I don't know about urine, and honestly, the logistics of getting urine on a 24-hour-old baby, like they usually urinate once in the first 24 hours. It's just like, I think it's like logistically like insurmountable to go with urine. Saliva.
I would probably agree.
Oh, right? Yeah, of course. I think with saliva, I mean, you could think about doing, you know, like genetic testing and so forth, you know, on the cheek swab. I don't really know much about, you know, how it's stored and transported in the media and so forth to kind of break out, be able to do like the PCR and then other tests on it. But I think it's an interesting idea. For me, the holy grail is the dried blood spot. But I think even with the best studies, which are not even commercial assays right now, you can get up to like an 85% sensitivity. Better than 30, but it's not quite there.
Great. Jeremy, also.
I was just going to say that, you know, as I was listening to this, I was thinking a lot about how social determinants of health could lead to, you know, some differential diagnosis and treatment, as we've seen in many things. And, you know, while universal screening wouldn't solve some of those more underlying treatment issues, it could address some of the barriers that social determinants of health could have to, or that, you know, the adverse social needs could have to diagnosis.
Yeah, and I should have mentioned it. There's just so much ground to cover, but there is a much higher incidence, 5-fold greater incidence of congenital CMV in women from marginalized communities and their children. This has been found from data in the South. And again, it's like the social determinants of health, the health education, you know, the access to prenatal care, probably like not the best access to quality childcare, and so maybe being around toddlers more, you know, all of that. So I totally agree, and I think that's a massive area in the literature that needs to be examined further.
Well, great. Thank you everyone for your questions. It's currently 10 a.m. One thing that I didn't get into, but I think this group would be a great group to ask about their thoughts on using claims data to identify CMV. There's a lot of people who could probably give you some insight to that that we could follow up on. So thank you all very much for participating, and obviously should put our contact information up there should you have further questions. And we really appreciate your coming and speaking with us today.
Thank you, everyone.
All right, have a good rest of your morning.
All right. Thank you.
Bye, thanks.